Okay, so let's unpack this. We are diving into what might just be the single most crucial topic in all of clinical practice.
Communication and history taking.
Exactly. I mean, when you think of modern healthcare, your mind probably jumps to, robotics, AI diagnostics, maybe advanced surgical techniques.
Hmm.
And yes, of course, those are vital. But the comprehensive source material we're analyzing today, these really detailed class notes and presentations, they remind us that the most foundational tool.
The most critical tool.
Right. It isn't hardware. It's effective human communication. It is the absolute bedrock of nursing practice.
And what's so fascinating here is that we aren't just looking at how to have, a pleasant conversation.
Oh.
We're dissecting a highly structured, almost scientific process.
Mm.
We've got this rich history of nursing to analyze, which shows how the role evolved from simple caregiving to, well, a professional science.
And then we get into the nitty-gritty.
The really specific, detailed mechanics of conducting a successful patient interview and compiling a comprehensive health history.
Absolutely. The amount of detail here is almost overwhelming, isn't it? From the reforms of Florence Nightingale that literally changed mortality rates globally.
All the way down to the 9 distinct elements we have to use to analyze a single symptom.
Exactly. So our mission today is crystal clear. We need to explain that professional journey nursing has taken, detail the essential skills for therapeutic communication, and walk through the structured 4 phases of the interview process.
And we also have to differentiate the types of data we collect, and this is critical, dissect every single component of the comprehensive health history.
Right down to that exhaustive, subjective review of systems.
It really is about building a systematic understanding for you, the learner. The level of accountability in modern healthcare, you can see it in tools like the Braden scale for pressure ulcer risk,
Hmm.
or in the specific conditions that now lead to a denial of reimbursement. It shows us that the quality of that first conversation is directly proportional to the quality and safety of the care that follows.
So that first interview is where it all starts.
It's where high-quality, safe patient care begins, and, frankly, where economic viability is often decided.
I love starting with history. I think it really grounds the modern professional role in this timeline of evolution and responsibility.
Yeah.
When we look back at the early history of nursing, say before the 19th century, it really wasn't the female-dominated, highly educated field we recognize today, was it?
Not at all. That's a crucial distinction. In the earliest days, these caregiving roles, which we would loosely call nursing, were incredibly diverse.
And surprisingly male-dominated in some areas.
That's right, especially around healing. We see roles ranging from healers and temple priestesses to just general male and female caregivers, volunteers, religious orders.
All focused on things like maternity, illness, and especially care for the dying.
Right. It was a respected function, but it was largely an untrained caregiving function.
And then comes this huge shift, the late 18th, early 19th century, when formalized education really starts to take root.
And that's the period that sees the field become predominantly female. Though the sources are careful to note that around 12% of the workforce was still male, even during this big transformation.
This historical inflection point, it just brings us inevitably to the pivotal figure, right? The lady with the lamp.
Florence Nightingale.
Of course, her name is synonymous with compassion, but her real enduring contribution was organizational and, well, statistical.
She essentially established the professional template for modern nursing.
Okay, so let's focus on the concrete impact of her work. She established a British hospital-based nursing program.
Which was a huge fundamental step. It was about recognizing nursing as an educated profession, not just some humanitarian vocation.
And the numbers just speak volumes about how effective her reforms were.
Especially during the Crimean War. She was the superintendent of nurses there. And she didn't just walk around with a lamp offering comfort.
No, she was a fierce advocate for sanitation, hygiene, data collection.
Organized care. She instituted these systemic hospital reforms, cleaning, ventilation, infection control, that resulted in a staggering quantifiable reduction in the mortality rate among the soldiers.
We're talking about dropping the rate from 40%.
40%, down to just 2%.
Wow.
That reduction is the hard proof that organized, educated nursing saves lives. It defines the importance of the environment of care.
That's amazing. She basically proved that the environment and the organization of care are just as critical as the medical treatment itself. And while Nightingale was formalizing the hospital setting, others were taking that care outside the walls.
Exactly. We should definitely mention Lillian Wald and Mary Brewster here.
Public health nursing.
They're credited with establishing it, making sure that health needs were tended to within the community, going into homes, meeting people where they lived.
Which established this really critical dichotomy in the profession that, still persists today.
Right, the intensive care of the hospital versus that community-focused preventative care model.
So moving into the 20th and 21st centuries, the professionalization just accelerates dramatically, and it's often driven by these massive social changes.
Oh, yeah. Look at the 1960s. The massive growth of the nursing workforce at that time wasn't an accident.
Not at all. It was directly tied to huge legislative and technological shifts.
That decade was truly explosive for healthcare. I mean, first, this establishment of Medicare and Medicaid.
Which provided coverage to huge new segments of the population who never had access before.
Right. And at the same time, employer health coverage expanded significantly. So you just have more and more hospital admissions.
And then there's the technology side.
The introduction of complex new tech, like intensive care units, ICUs, which demanded much higher levels of specialized skill. All of this drove a huge, urgent demand for highly educated and professionalized nurses.
And the 70s really seemed to cement nursing as a professional science, not just a vocation.
That's when the NIH established the National Center for Nursing Research. And that validation, it signaled that nursing theory and practice were worthy of serious, federally funded scientific inquiry.
And we also see the 1975 establishment of the NCSBN.
The National Council of State Boards of Nursing.
Right, which granted state boards the autonomy to provide licensure, further formalizing that professional standard across the country.
The 80s then saw the rise of advanced roles. Nurse practitioners, nurse midwives, clinical nurse specialists, all emerging from graduate nursing programs.
This was partly a response to the ongoing consolidation of hospitals, right? They demanded more specialized roles.
Exactly. But then the 90s brought this huge shift in workforce organization and task delegation.
That's the era where unlicensed assistive personnel, or UAPs, and licensed practical nurses, LPNs, started taking over more of the basic tasks in ADLs.
Right, activities of daily living, so walking, bathing, eating, changing clothes.
But crucially, the sources emphasize that this delegation didn't diminish the role of the registered nurse, the RN.
Oh, quite the opposite. This shift actually increased the importance of the RN's role. It demanded superior critical thinking skills in two main areas.
Okay, what were they?
First, ensuring the appropriate delegation of tasks. And second, focusing the RN's energy more intensely on comprehensive patient assessment, clinical judgment, and advanced interventions.
So the RN became the coordinator, the critical thinker, the primary assessor.
Precisely.
And then we look at the 2000s, and the challenges just keep evolving. You have rapidly accelerating scientific advances, profound changes from the Affordable Care Act.
And most critically for this discussion, significant changes in insurance practices.
Specifically, that emphasis on reimbursement, or more often denial of reimbursement.
Yes. The system is now heavily focused on accountability and preventing errors.
We have to recognize the innovators who helped define safety during this period, too.
Absolutely. We have Anita Dorr, who created the crash cart.
That movable tool chest of emergency resources that allows for a rapid, standardized response, that's a system safety innovation driven by a nurse.
And Barbara Braden, who created the Braden scale. For our listeners, this isn't just a number. It's a standardized, objective tool used everywhere for assessing a patient's risk of developing pressure ulcers.
It forces the nurse to quantify risk factors, again, linking assessment directly to prevention. These innovations just show how nurses drive systemic changes in safety and quality.
And this necessity for systemic safety and cost control, it leads us directly to the expansion of nursing roles into case management.
The sources really emphasize this role as absolutely critical for controlling costs and ensuring continuity of care.
The case manager nurse, they're coordinating care, handling referrals for services like physical therapy or medical equipment, and collaborating with all these different teams.
All to figure out exactly what the patient needs for a safe, successful discharge.
It's the intersection of clinical skill and economic reality.
Which is precisely where a flawless interview becomes not just a nice clinical necessity,
but a profound economic imperative for the entire healthcare system. Errors are now heavily penalized. Hospitals have to demonstrate quality outcomes, and if they don't,
reimbursement is denied.
That's a powerful statement, isn't it? Let's look at those specific, compelling examples, the sources list, because they illustrate the astronomical stakes involved.
Okay. If these preventable conditions occur, reimbursement is often denied. What's first?
A foreign object retained after surgery. That speaks to pure human error in high-stress situations.
Surgical site infections and air embolism. Both are considered catastrophic, preventable events.
The development of stage 3 and 4 pressure ulcers. This ties directly back to comprehensive assessment and using tools like the Braden scale.
A transfusion reaction due to incompatible blood. A high-stakes, preventable error that can be fatal.
Complications from poor glucose control, which often stems from inadequate patient teaching and history analysis.
And finally, falls, catheter-associated infections, and deep vein thrombosis or pulmonary embolism.
Every single condition on that list could be mitigated or entirely prevented by a perfectly executed comprehensive assessment in that initial interview.
So if we connect this to the bigger picture, the shift toward professional responsibility and extremely high accountability just demonstrates why a comprehensive history is an economic and safety imperative.
Exactly. Getting the full subjective picture up front allows the nurse to mitigate the risk factors for nearly every one of those conditions. The assessment has to be perfect because the stakes are just astronomical.
The stakes are clearly economic and clinical, so how do we ensure the quality of that foundational data is flawless? That brings us to the fundamental toolkit of communication.
It does. Everything we've discussed relies on establishing effective therapeutic communication.
All nursing practice depends on establishing an effective nurse-patient relationship.
Right, and that's built on therapeutic communication, caring, and empathy. The source material really emphasizes that this is an art you have to practice and repeat to develop your own effective individual style.
It's not a script you read.
No, it's a dynamic interaction.
Let's start with nonverbal communication, because that often provides clues that words don't. What are the key nonverbal components a nurse has to master?
The list is comprehensive because every aspect of the nurse's presence communicates something. It includes physical appearance, facial expression, posture, gestures, eye contact.
Positioning in relation to the patient. That's a big one.
A huge one. And voice tone, use of touch, and underlying all of it, active listening.
I think that positioning element is fascinating. Communicating at the patient's eye level is so often overlooked, but it's profoundly important.
It immediately establishes rapport. It reduces that perceived power imbalance. The nurse isn't towering over a vulnerable patient. They're meeting them as equals.
And then there's touch. The source material highlights that touch is essential to the physical exam itself. You have to touch, to palpate, to percuss, to assess.
However, culturally, it is not acceptable in all situations or with all individuals.
Right.
Which makes it absolutely necessary for the nurse to ask permission to touch the patient before initiating contact, even for an assessment. It's a sign of respect.
That attention to detail is just foundational for cultural competency. Now, moving to verbal skills, effective interviewing, as you mentioned, is learned through practice. What about the technical aspects of our speech patterns?
Well, you should use a moderate pace and volume with clear articulation. But professionalism requires immediate modification based on the patient's needs. If a patient has hearing problems, you have to modify your approach.
Slow down, articulate clearly.
Maybe speak slightly lower, but not yell. And if you're dealing with a patient who has limited English, you should use simple, clear language, but maintain a normal volume.
Avoiding that common, unhelpful tendency to shout.
Right. Shouting doesn't aid comprehension. It often just increases tension.
So let's get into the therapeutic techniques, because these are the active tools of listening that maximize information gathering. The foundation, of course, is active listening.
Right. Fully concentrating and processing what's being said. But once you're listening, how do you respond effectively to draw out the story?
We have a great list of techniques here that serve different purposes. First up is restatement.
Okay, so this relates specifically to the content of the communication. If the patient says, "My knee started hurting yesterday after I walked up the stairs," the nurse might restate.
So the pain began yesterday after you used the stairs.
Exactly. It validates the facts.
Then there's reflection. This is a bit broader and, I think, more powerful.
It is. Reflection means summarizing the main themes or the underlying emotions of the communication, so that the patient describes their knee pain in a way that shows fear about needing surgery.
You might reflect, "It sounds like you are quite worried about what this pain might mean for your future mobility."
You're capturing the emotional takeaway, not just the facts.
Then we have elaboration, or facilitation. This is critical for drawing out more detail.
And is often achieved with simple prompts. Things like nodding or saying, "Tell me more about that," or just go on.
You're assisting patients to more completely describe their difficulties without putting words in their mouth.
I think silence is probably the most powerful and the most undervalued technique.
And it requires the most discipline, for sure. Purposefully allowing patients time to gather their thoughts can prevent premature answers and often uncovers deeper truths.
But silence has to be strategic, right? Isn't there a risk that it creates anxiety for the patient or wastes critical time?
That's where training comes in. The nurse has to recognize the patient's comfort level. In a truly acute setting, yeah, silence might be inappropriate. But in a general history interview, a 10 or 15-second pause after asking about sensitive subjects like substance use or domestic violence, it allows the patient to process and choose their words. It's an intentional invitation to speak.
That's an excellent point. And
Yeah.
sometimes you need to pull the conversation back, especially if the patient is rambling. That's focusing.
Redirecting patients back to the pertinent topic. You might say something like, that's important, but let's go back to when the chest pain first started.
Then there's clarification. This is asking questions to figure out what a patient means when their words are unclear.
For example, if a patient says, my head feels funny.
You have to clarify. When you say funny, do you mean dizzy, numb, or something else? It prevents dangerous assumptions.
And finally, summarizing. This technique concludes a segment by reviewing and condensing the information into the 2 or 3 most important findings.
It's a safety check, really. It ensures mutual understanding before moving on.
So those are the tools we want to use, but the sources also give us a clear checklist of non-therapeutic responses.
The things that actively undermine the interview.
Exactly. The pitfalls nurses have to consciously avoid.
Well, the list includes offering false reassurance,
Don't worry, everything will be fine.
giving unwanted advice. If I were you, I would. Asking biased questions like, you don't smoke, do you?
Making abrupt changes of subject, allowing distractions, using technical jargon.
And the simplest one, just interrupting the patient.
That distinction between advice and information is so key. Giving unwanted advice immediately shifts the dynamic and places the nurse in this superior, judgmental role.
It does. It violates professional boundaries. And speaking of boundaries, professional expectations clearly define what non-professional involvement looks like.
Right. Establishing social, personal, or economic ties. Engaging on social media.
And the source material states unequivocally that a sexual boundary violation is never acceptable within the therapeutic nurse-patient relationship. These rules exist to protect everyone involved.
And in terms of cultural competence, we have to recognize that cultural differences are far broader than just country of origin.
They can relate to ethnicity, age, degree of acculturation into Western society, any combination of these. The nurse has to be constantly assessing the patient's individual needs.
For patients with limited English, the sources stress the necessity of working with a certified interpreter.
Right. Relying on family members, especially children, to interpret can lead to profound errors and just inappropriate disclosure of sensitive information.
And we also have to be sensitive to gender identity and sexual orientation, ensuring the patient feels safe and respected throughout the entire process.
Okay, so now that we have the soft skills and the therapeutic mindset established, let's talk about structure. The patient interview isn't just a free-flowing chat.
No, it has 4 distinct professional phases that guide the process logically and efficiently.
Yes, starting with the pre-interaction phase. This is that vital homework phase.
This is defined as compiling existing data and preparing for the interview using medical records before you even step into the room.
Exactly. The nurse is checking the chart for previous admissions, lab work, physician orders, just getting a baseline understanding of why the patient is there.
Then you move into the beginning phase. This is where the nurse introduces themselves, clearly states their role, and states the purpose for the interview.
Establishing those expectations and that trust immediately.
And then the majority of the work happens in the working phase.
This is the active data collection phase, where the nurse uses all those therapeutic techniques we just discussed. This is where we see the strategic use of 2 main types of questions.
First, closed-ended or direct questions.
These are for specific, quantifiable information. Like, on a scale of 0 to 10, what is your pain level? Or, do you have allergies to penicillin?
They're excellent for filling in checklists and confirming facts.
And crucially, this is where we use open-ended questions.
Right. We use those at the beginning of the interview and whenever a new topic comes up.
It allows the patient to speak in their own words, giving broad answers to things like, tell me what brought you to the hospital today. This blend ensures both comprehensive data and narrative insight.
And finally, we enter the closing phase. This concludes the interview and involves 2 main tasks.
First, summarizing and stating the most important 2 or 3 problems or patterns you identified to ensure you're on the same page.
And second, reporting any information that is required by law, like suspected abuse or neglect, following protocol.
So, moving on to data sources. We have to differentiate primary from secondary. This helps us gauge the reliability and the perspective of the information we get.
The primary data source is always the patient themselves when they're able to provide information.
And the information they provide is considered subjective data, what they report feeling, perceiving, or experiencing.
I have a sharp pain in my side, or I feel anxious.
Secondary data sources include documentation, family members, caregivers, or other healthcare providers. And when you're relying on these, the nurse has to critically assess historian reliability.
Did the family members seem to understand the patient's condition? Are they coherent? Do their reports contradict the patient's own record?
The nurse's role here is multifaceted. You have to record exactly who the information provider is, note any discrepancies between the sources,
And identify any additional sources you might need to confirm the history, making sure the data is robust and triangulated.
and the intensity and scope of the interview, it depends entirely on the patient's immediate situation.
Which is why we classify 3 distinct types of health histories.
First is the emergency history. This is gathered when time is critical, when a patient's life or limb is threatened.
Information is focused solely on the immediate, life-threatening problem. What happened? What needs intervention right now?
Then there's the focused history. This is used when the assessment is centered on the current, specific situation or symptom that is not immediately life-threatening.
Like a patient with a localized wrist fracture. You'd get a focus history on the injury and pain, not a full system review.
And the gold standard, the most detailed method, is the comprehensive history.
This requires gathering all medical, social, functional, and psychological information about the patient. It's the full picture that serves as the baseline for all future care.
Okay, so let's dedicate some serious time to breaking down that comprehensive health history into its core parts. This is where that systematic collection of subjective data really shines.
We start with the obvious, collecting demographic data. Name, age, preferred language, insurance, all that.
But the first clinical component is the reason for seeking care, often called the chief complaint.
This is a brief, often quoted statement in the patient's own words. I came in because of chest pain.
And that single sentence initiates the history and leads us directly into the deep analysis of the current problem.
That reason for seeking care immediately leads us into the symptom analysis, or the history of present illness, the HPI.
And this isn't just asking, where does it hurt? It is a highly structured, rigorous analysis using 9 distinct elements to thoroughly characterize the symptom.
Let's walk through this using a common example, say a patient with generalized back pain. These 9 elements ensure we don't miss anything.
First, onset. When did it start? Was it sudden or gradual? This helps determine if it's acute or chronic.
Second, location. Where exactly is the symptom? Is it localized or does it radiate down the leg? Radiation is a huge clinical clue.
Third, duration. How long does the pain last? Is it continuous or does it come and go?
Fourth, character. This is one of the most important clinical clues. What does it feel like? Sharp, dull, throbbing, aching, burning.
For back pain, a sharp shooting pain might suggest nerve involvement, while a dull ache suggests muscular strain.
Fifth, aggravating factors. What makes the pain worse? Does bending over increase it? Walking. This links the symptom to activity.
Sixth, relieving factors. What makes it better? Does rest help? Heat, ice, pain medication. This assesses their current self-care.
Seventh, timing. When does it occur? Morning, evening, after meals, only with activity. Pain worsening in the morning could suggest inflammatory arthritis.
Eighth, severity. How bad is it? Usually measured on a pain scale 0 to 10. This provides a quantifiable measure that you can track over time.
And finally, ninth, associated symptoms. What other things happen when the back pain occurs? Numbness, tingling, fever, weakness.
That is 9 dimensions that have to be documented completely for just one symptom. It's incredibly thorough.
And moving past that immediate complaint, we delve into the past medical history, or PMH.
This section captures all the health data that came before the current issue and provides the necessary context for what's happening now.
The components of the PMH are extensive. They include past illnesses, both acute like pneumonia and chronic like hypertension or diabetes, and their treatments.
We also record a history of childhood illnesses, measles, mumps, chickenpox immunization status, and a detailed surgical history, specifying the type of surgery and the year it happened.
And specifically for women, we record a full obstetric history.
Right, which is essential. This involves 2 terms, gravida which is the total number of confirmed pregnancies.
And para, which is the number of births carried past 20 weeks. So a patient who is G3P2 has been pregnant 3 times and given birth twice.
We also document the results of routine health screenings.
So to quickly confirm a core concept here, if a patient reports a diagnosis of diabetes mellitus type 2 3 years ago, that information is definitively documented in the
Draft medical history. The PMH section. It's an established diagnosis, not a current active symptom, though it certainly impacts the treatment plan.
Right. And beyond that, the PMH also requires documentation of all current medications, including over-the-counter and supplements, and why they're taking them.
A full list of known allergies and what the reaction is. And finally, a thorough family history to identify genetic predispositions and risk factors.
The comprehensive history also has to look at the holistic picture of the patient's life, not just disease processes.
Right, and this starts with functional health assessments. These assess the effect of health or illness on the patient's quality of life and independence.
This includes the detailed ADL assessment activities of daily living, covering the patient's ability to perform basic self-care tasks.
And we also review patterns related to nutrition, exercise, and sleep. Poor sleep hygiene, for example, can profoundly affect a person's ability to heal.
And specifically for pediatric patients, the assessment has to incorporate growth and development, looking closely at whether the child is meeting expected milestones.
Any lag there is a critical cue for early intervention.
And the assessment wraps around to the crucial psychosocial and lifestyle factors.
This includes a comprehensive social assessment, questioning about employment, living situation, support systems, and significantly detailed questions about alcohol and substance use,
including tobacco and vaping.
We also need a cultural and spiritual assessment to understand the patient's beliefs. A full mental health assessment asking about mood, anxiety, prior diagnoses.
And critically, the nurse has to perform a specific assessment for neglect, abuse, and violence, given how prevalent these issues are.
These questions must be asked privately and sensitively.
And finally, sexual history and orientation are required elements of this holistic assessment, vital for preventative care and understanding risk factors.
Okay, we have reached the most comprehensive, detailed, and often challenging part of this deep dive, the review of systems, or ROS.
We need to emphasize again that the ROS is purely subjective. The nurse is collecting reported symptoms, not performing the physical exam yet.
Yes, this is a head-to-toe inventory, but it is purely based on the patient's report. We're trying to determine if the patient is experiencing signs or symptoms within a specific system that they haven't mentioned yet.
Let's walk through the full detailed listing provided in the source material, maybe grooming some related systems for better flow.
Sounds good. We begin with the foundational elements, general health state and nutrition.
Questions here cover weight gain or loss, fatigue, weakness, malaise, pain, changes in usual activity, fever, and chills.
For nutrition, we address risk of malnutrition or obesity, nausea, vomiting, daily intake, changes in appetite. We also document screening info for cholesterol, triglycerides, and elevated lipids.
Moving to the largest organ system, skin, hair, and nails.
Here the nurse asks about a history of skin, hair, or nail disease. Rash, itching, pigmentation, or texture change, lesions, excessive sweating, dry skin, hair loss, and brittle or thick nails.
Now let's move up to the sensory systems, starting with head and neck.
We're looking for a history of high or low thyroid hormone level, headaches, syncope or fainting, dizziness, and sinus pain.
The eyes assessment is next. This covers a history of poor vision, glaucoma, cataracts, use of contacts or glasses.
And specific symptoms like a change in vision, blurring, double vision, light sensitivity, burning, redness, discharge, and crucially, the date of the last eye examination is recorded.
For the ears, we assess for a history of hearing problems, infections. Active symptoms include ear pain, change in hearing, tinnitus or ringing, and vertigo.
Next up, nose, mouth, and throat. History questions cover mouth or throat cancer.
Active symptoms include colds, sore throat, nasal obstruction, nose bleeds, cold sores, bleeding gums, tooth pain, ulcers, enlarged tonsils, dry mouth.
And we also assess difficulty chewing or swallowing and the date of the last dental cleaning. Oral health is so linked to systemic health.
Let's move to the core life support systems, thorax and lungs.
History includes emphysema, asthma, or lung cancer. Current symptoms reported are wheezing, cough, sputum production, and shortness of breath.
And we document the last chest x-ray and last tuberculin skin test and their results.
The heart and neck vessel section includes a history of congenital heart problems, heart attack, heart surgery, heart failure, arrhythmia, or murmur.
Active symptoms are chest pain, palpitations, and exercise tolerance. We also record results from screening tests like an EKG or stress test and their typical blood pressure.
For the peripheral vascular system, the history includes high blood pressure, PVD, blood clots. Symptoms include peripheral edema, ulcers, claudication, pain, and tenderness.
And any screening tests like an ankle brachial index are documented here as well.
Okay, let's cover the breast assessment now. This covers a history of breast cancer or cystic breast conditions. For adolescents and males, gynecomastia is assessed.
Symptoms noted include pain, tenderness, discharge, lumps. Screening data required includes the last mammogram and results and the frequency of self-examination.
Moving down to the processing systems, abdominal, gastrointestinal.
History here covers colon cancer, GI bleeding, gallstones, liver failure, hepatitis, pancreatitis, colitis, ulcer, or reflux.
Current symptoms assessed are appetite, nausea, vomiting, diarrhea, food intolerance, constipation, change in stool color, blood in stool. And screening results, like the last colonoscopy, are needed.
The abdominal urinary system includes a history of renal failure, kidney disease, UTIs, and kidney stones.
Active symptoms include pain, change in urine, painful urination, urgency, frequency, waking at night to urinate, and incontinence.
Next, the systems related to movement and control. For the musculoskeletal system, history covers previous injury and arthritis.
Symptoms include joint stiffness, pain, swelling, restricted movement, deformity, change in gait or coordination, strength, cramps, and weakness.
The neurological system assessment requires a history of head or brain injury, stroke, and seizures.
And symptoms reported are tremors, memory loss, numbness or tingling, and loss of sensation or coordination.
Finally, the genital systems, which are assessed separately. For male genitalia,
History includes undescended testicle, hernia, and testicular cancer. Symptoms are pain, burning, lesions, discharge, swelling. Protection against STIs is assessed, along with testicular self-exam frequency.
and for female genitalia.
History includes ovarian or uterine cancer, ovarian cysts, endometriosis, and number of pregnancies in children.
Symptoms are pain, burning, lesions, discharge, itching, rash. We also assess menstrual changes, protection against STIs, and the results of the last Pap smear.
That systematic, exhaustive review is a comprehensive subjective data set the nurse relies on. Its completion ensures no stone is left unturned.
Now, wrapping up the components, we have to consider lifespan considerations because the interview approach changes so dramatically depending on the patient's age.
For infants and children, interviews are primarily with parents or legal guardians. The nurse has to validate who's who.
And key medical information collected here always includes pregnancy, birth, perinatal history, immunizations, and critically, a thorough assessment of growth and development milestones.
Adolescents present a unique challenge and opportunity. They should begin to participate actively in the interview process.
Recognizing their emerging autonomy and the often confidential nature of many of the questions.
Exactly. And for older adults, there are unique complexities. The nurse has to establish the roles of others present and actively explore possible sensory deficits, hearing, vision, cognitive love, that could impede communication.
And they often have far more complex health histories spanning decades and multiple comorbidities.
Right. And we also need to intensively assess lifestyle choices that affect their overall health, as those choices heavily influence their current status.
What a deep dive. We started with Florence Nightingale reducing mortality from 40% to 2% through organized care.
And we finish by walking through a detailed 16-system subjective review.
The core takeaways are undeniable. The foundation of safe, effective care is that therapeutic interview, built on essential techniques like active listening, differentiating restatement from reflection.
And the discipline of purposeful silence.
We establish that logical, professional flow of care. The 4 phases: pre-interaction, beginning, working, and closing.
We clarified the crucial difference between primary, subjective data from the patient and secondary data from other sources, and we detailed the comprehensive scope of the history, culminating in that incredibly detailed review of systems.
Here's where it gets really interesting for me. What we see is that the best medical outcomes start not with a prescription or even a scan, but with a perfectly executed, empathetic, and comprehensive conversation. The integrity of that conversation directly impacts the quality of the data, which in turn impacts the safety and, yes, the economic viability of the care delivered.
The human element is the ultimate safety mechanism.
This raises an important question then. If the nurse-patient relationship is the foundation of practice, and we know that nonverbal competency is half the battle, the eye contact, positioning, facial expressions. How do future technological advances challenge that?
You mean things like widespread AI documentation that draws attention away from the patient, or purely virtual health visits?
Exactly. How do those things challenge our ability to maintain that nonverbal competency and therapeutic rapport? It demands that we find new ways to build that deep foundational trust, even when technology is in the middle of the relationship.
That is a thought worth mulling. And building on the source material, which highlights that the complexity of older adult health histories is often linked to lifestyle choices.
Right.
How might a health history interview, specifically designed around positive lifestyle reinforcement rather than just illness diagnosis, reshape the future focus of healthcare assessments?
Encouraging proactive behavior might start simply by strategically changing the questions we ask in the working phase of the interview, focusing on strengths and goals rather than just deficits and symptoms.